by the atom urine. So he asked about the LH, right? So I search about the all analytes, including the FSH and LH. We have a comparison of in the previous presentation. The LH is SNIPE second generation comparison with the Roche LH, the FSH second generation comparison with the Roche FSH, and the SNIPE prolactin second generation is the comparison with the commercially available Bachman prolactin, and the testosterone second generation from the SNIPE is compared with the commercially available Bachman testosterone, and the progesterone is also the Bachman comparison, the estradiol comparison with the gold standard. That's in a mass spectrometry. In the beta ECG, we have a second generation comparison with the Roche, and DHES, we have a comparison with the Bachman. So this is all about the comparison of the commercially available fertility markers in the previous slide. So we have this information about the comparison of different analytes. So usually the Bachman, Roche are the parameters which I have compared with the SNIPE fertility markers, right? Okay, so let's start with our second presentation. You can see my screen. Okay, so thank you. So let's start with the next presentation. That's an SNIPE infertility panel. So in this presentation, we have 4 parts. The first part includes the assay introduction, their features and the benefits. And the second part is the clinical utilization application, and we will discuss about the symptoms and the features and then treatment as well. And the third part contains what is the solution provided by the SNIPE for the evaluation of infertility and their markers and their clinical utilization and their comparison with the reference standard and or the gold standard available in the market. And then the last, we will talk about the market of infertility and their prevalence, and then different diseases from the sales and marketing point of view. So let's start with the essay introduction. So as you know that basically the first marker, fertility marker, is called the testosterone. So you know that this testosterone and the steroidal hormone, which is especially produced by the endocrine tissue, the Leydig cells in the male testicular, which is almost the 95% of total testosterone. So this hypothalamus and the pituitary release the hormones like FSH, and then this FSH and LH has an impact on the Leydig cells in the male testicles, and these male testicles release this testosterone values for this mass in the sperm tubules. So it is also produced by the adrenal glands, which is lies on the kidneys, and in the both and male and female, but its the percentage is just a 5%. So this is a small amount is also produced by the ovaries in the females as well. So this is about the production or a biosynthesis of the testosterone from different organs. So if we talk about the SHBG, this SHBG stand for the sex hormone binding globulin, and as we know that these are the glycoproteins, and these glycoproteins are 95 kilodeltas weight, and that's produced by the liver and the testes, and that transport the sex hormone in the blood and the biologically inactive forms. So that's the main function of this sex hormone binding globulin, and on the basis of which they play a vital role in the fertility as in fertility markers. So, what is the binding affinity of this SHBG? Basically, dihydrotestosterone is converted into a testosterone, and then this testosterone is converted into the androstenediol, and then estradiol, and then estrone and DHEAs and a progesterone. So this is then the binding affinity of dihydrotestosterone to that, and then these are the equilibrium constant at different temperature at 37 degrees centigrade, that the 5 alpha dihydroxytestosterone DHT as in 5.5 kilo delta to 10 to the power minus 1 molars, and then testosterone is 1.6, and then along with the estradiol and the progesterone values. So this is the binding affinity of SHBG with the other fertility hormones and the other related hormones. So what are the free testosterone? So as we know that in the human body, there is almost about 2%. The testosterone function is the blood in the 2% of testosterone in the body is an active body is inactive. So the free testosterone is not attached to the binding protein that would prevent it from the interaction with the receptors. So the sex hormone binding testosterone is almost a 60%, and the 38% is albumin bound testosterone is 38%. Only the 2% is a free testosterone. So this while the 98% is the bounded form. So about the 38% of this testosterone is bind with the albumin, and this binding albumin and the testosterone is a weak and can be easily broken in order to create a free testosterone when needed. But in a healthy young man's, there is 60% of his testosterone is attached with the SHBG, and this SHBG bound to the SHBG cannot be used by the body and lose their anabolic effects. So you can see there the bioavailable values are the free testosterone or a testosterone with the albumin, while the testosterone plus SHBG is called a total testosterone levels, and they are circulating in the blood streams of the person. So if we talk about the free androgen index and the free testosterone index, so there's one formula. If we want to calculate the free androgen index and the free testosterone index, so that indicates the amount of bioavailable testosterone and helps to assess the specific androgen abnormalities. Like you know that then the circulatory testosterone, the sex hormone binding testosterone is 60%, then the bioavailable is the 40%, and then the free bioavailable 40% is how much is the albumin bounded and how much is the free testosterone. So this purpose they check that the free androgen index through this formula. You need a 2 assay to perform that. After performing that, you can calculate the free androgen index. You have to divide the total testosterone with the SHBG, and after dividing it, you can multiply it, and then you can get the value of free androgen index. So how you can calculate the bioavailable testosterone? You have to add the free testosterone plus the albumin bounded testosterone, which is almost a 38%, but in the clinical condition for the specific androgen abnormalities, the values becomes variables. So for this purpose, the free androgen index calculation is available. So then we have to go for a free testosterone calculation. So for this purpose, we need values like albumin, SHBG, and testosterone values. On the basis of these three values, albumin, SHBG, and testosterone values, we can calculate the free testosterone and the bioavailable testosterone levels through this formula. These are available on internet, then anybody can use this formula, or they can put the formula in the instrument. Then on the basis of these value, they can calculate the results. So if we talk about the free testosterone is more accuracy. So you can see the equilibrium dialysis. Here, when the comparison of the reference method of the free testosterone with the 5 different calculation method in around the 4,000 sample base on a total testosterone and sex hormone binding globulin measurement. So you can see that there are these are the 5 different calculation methods. 1, 2, 3, 4, 5, and on the basis of equilibrium dialysis, that then the comparison of the reference method of the free testosterone, that's calculate that gives you the reliability of the free testosterone. So if you more go to the total testosterone, which measured by the commercially available analyzers of the immunoassay comprising, which includes the Bachmann and Coulter axis, Siemens Advia, Abbott Architect, I2000, and Siemens Centaur, Roche Alexis, E170 2010, Siemens Similite 2000, J&J Vitros. So these are the instruments used for the total testosterone, and when their sex hormone binding globulin was using 2 available SHPG like the Emilite 2000 and Roche Alexis E170, that the total testosterone value, the sex hormone binding globulin values, helpful for the calculation of the free testosterone, and then this characteristics of the subject for the free testosterone and 5 other calculated formula helps to computing that the characteristics of the free testosterone. So you can see here there's an indifferent manual calculation for the free testosterone formulas are also available, but through this process that can be calculated easily. So if you go for another fertility marker, this is called androstenedione. So the androstenedione or AD, this is basically an steroidal hormone. Excuse me. So this is basically an steroidal hormones, and it's produced in the adrenal glands and the gonads, and its a major function is basically the challenge for this analysis of androstenedione is the diurnal, cyclic, and circannual variations. So the major precursor of it's a basically androstenedione is a major precursor of testosterone and estrone levels. So if we go to the further for the analysis of androstenedione, you can see that this is the biosynthesis because this is the major precursor of testosterone and estrone. That's why you can see here that the androstenedione through the cholesterol conversion is pregnenolone, and then this pregnenolone has a different pathway, then it's converted into the aldosterone, and then dihydroxytestosterone, and then dextrone with the osteone to estradiol, and then with the cortisol. So these are the different pathway through which then the biosynthesis process through which the cholesterol with the help of amino glutamide and the other enzymes is converted to DHASO, androstenedione, testosterone, dihydroxytestosterone, estriol, cortisol, and then corticosteroid and the hydroxylase to the aldosterone synthetase enzymes. So this process, we have more information about the androstenedione diurnal variation. So what is a diurnal variation? Basically, at a different time in a 24-hour cycle, if the values is variation is occurred, that's called a diurnal variation, right? So if the highest peak value is observed in the androstenedione in the morning samples as compared to the evening samples, that's called a diurnal variation. That's not only androstenedione is a challenge of diurnal variation, it's an also have a plasma level increase steadily about at the different age. At the age of 7 years of the life, then they gradually decline after the third decade. You can see that that's incline, that's an increase steadily, and it's up to the age of 18 years. Its optimum level is increase, and then after that there is a gradually decrease in the values of that. So that's called circannual variation. With the age, if the values are changes, concentration of serum concentration of androsten at the different male and female different ages is concentration is changes, that's called a circannual variation. So this is also observed in that. If we talk about the cyclic variation, what is the cyclic variation? Basically, androstenedione, it's depends upon the days from the estradiol peaks in comparison with the estradiol levels. The androstenediol exhibit a cyclic variation. What is the cyclic variation? During the menstrual cycle, they have been in highest near the mid cycles. So you can see at the different pregnancy in the week, like the testosterone level, androstenediol level, and the ratio. You can see here that's in peak values of achieve in the mid cycle during the pregnancy, and there is an increase in the plasma levels of different levels at that uh, duration. So they have a cyclic variation, diurnal, cranial varitions. That's why this is a challenge for the industry dion evaluations. So if we talk about more the anti-malarial hormones, so in this anti-malarial hormone is basically a glycoprotein which has an space structures of like this, and then is secreted by Sertoli cells in the male, and is also secreted by the prenatal follicles of the ovary in the females. So this is a highly specific marker in the follicular development and the maturity of the follicles in the women's, and an important role in the sexual development uh, of female characters, especially. So that the variation tendency on the basis of physiological basis, they have anti-malarial hormone. You can see that the fetal life, that's anti-malarial hormones values are increasing at that stage at the time of birth. That the childhood is remains same, and then in the between the puberties and then the adult age, that's the decreased values. So if we compare with the testosterone, the profile of the serum level of testosterone and the anti-malarial hormone in the male has been tested, and then it's been observed that there is an inverse relation of AMH and testosterone. That's an variation tendencies also exist in that. So we go to the clinical application. In this application, we have the further classification of the infertility panels. Like as we know that the overall, if we exclude the cause of the infertility, 30% caused by the male and the 30% by the females, and the rest of the 25% is still unexplained. So the remaining 10%, usually the male and female both have a cause of infertility. Only the 5% are the other cause of infertility. So if you more focus on the just 30% of male infertility panels, uh, excuse me, yeah, that's the 30% male infertility cause contains the 10% hypogonadisms and 5% immune system factors, and still a 34% is unexplained reason for the infertility in the male cause of the male. The remaining 3% and the 6% is sexual factors and systematic disease, urogenital infection in 9%, and undescended testicles in 8%. With that, other cause is 8%. So these are the overall distribution cause of the male infertility, which is the major causes in the hypogonadisms, with the non-major cause is in hypogonadism. while in the female, 30% infertility cause leads to the 40% of tubular factors and the 40% of ovulatory disorders, and still a 15% is unexplained infertility in the female is also existing, and the 5% is uterine factor of 5%. So the ovulatory disorder, 40%, majority part is 85% of PCOS, polycystic ovarian syndrome. Only the rest of just 15% are the other cause of ovulatory disorder and female infertility reason in that. So if you go to the hypogonadisms, basically, as you know, that it's a medical condition in which testis cannot produce the enough testosterone, and the development of the fetal and the secondary sex characters are decreased development and impaired growth of body hairs, and the erectile dysfunction is observed. So these are the clinical symptoms of hypogonadisms, and then the further clinical evaluation is required. So, so if we talk about androgen deficiency and erectile dysfunction, so in between 2.1% to 21% of men's erectile dysfunction have a low testosterone, and then depending on the test used to measure the testosterone. So this is important. The erectile dysfunction is usually occurs due to this low levels of testosterone. And there are a few journals that, like the Journal of Clinical Endocrinology and the Metabolism, this has been reported that the testosterone therapy in a man with the hypogonadism is endocrine practical guidelines are given. And according to these guidelines, there are a few more parts. You can see that for the condition in which the FT concentration is, free testosterone concentration is recommended, you can see there is an algorithm that we have already discussed in detail in the previous presentation about the history of physical examination and the performing of the total testosterone and the free testosterone along with the SHPG. If the low total testosterone normal values are existing, so you can go for the further testing of total free T3 and the low T3 and the normal low total, and then diagnosis of the hypogonadism is confirmed. When you have to measure the LH and FH, you can further hypogonadism can be distinguished into a secondary hypogonadism and the primary hypogonadisms, and then you can go for a further Klinefelter syndromes or karyotypings to diagnose that, and also the potential reversible function, which may include the measure the prolactin, iron saturation, to the pituitary hormones and MRI sections to rule out that functions. So there are the few conditions associated with the decreased sex hormone binding concentration, like obesity, diabetes mellitus, glucocorticoid, and progesterone and androgen steroid, nephrotic syndrome, hypothyroidism, acromegaly, and the polymorphism in the sex hormone binding gene. So these conditions associated with the increased sex hormone binding conditions like the aging, HIV, infection, cirrhosis, hepatitis, um, and the use of sub-anticonvulsant, use of estrogen, and polymorphism in the sex hormone binding globulin gene. So the total testosterone concentration in the borderline zone around the low limit of the normal range, also the indicator for the some hypogonadism condition, either the primary or secondary, or then can be considered cause of other on the basis of the value of LH, FSH, free testosterone, and testosterone levels. So that's an clinical application of these assays in conjunction with the others. And then this is. So if we talk about the PCOS, so you can see that the polycystic ovarian syndrome is basically an hormonal disorder, which is common among the women of reproductive age, and the woman with the polycystic ovarian syndrome they have an infrequent and prolonged menstrual period, or the excess male hormone, that's in androgen levels. So you can see here that the cause, the symptoms, and the prevalence guidelines and the treatment. So this is very typical examples of polycystic ovarian syndromes in male infertility. So let's move for more information. What and how is the diagnosis of the PCOS? So you see, the best example or a best tool used for the diagnosis of the polycystic ovarian syndrome is an ultrasonic scope of the polycystic ovary. So if the polycystic ovary observe in terms of characterization of the multi-small cyst aligned with the outer, you can see here, aligned with the outer capsule of the ovary, and when an appearance of a chain of pearls in the ultrasound is observed, if you see here, this is the normal ovary, and this is the normal ovary. They have many cystic ovarian, that the small cyst found in the ovary. That's why they call it a polycystic ovary. So, and this through this imaging technology and the clinical findings and the other serological testing helps to diagnose the PCOS. So the clinical presentation for the PCOS, you can see that the ovarian dysfunctions, like if the women have early signs and symptoms of PCOS, they have an acne, they have hirsutism, they have irregular menses, alopecia, they have an obesity, achondrosis nigricans, they have a mood disorder and depression, and then polycystic ovaries along with the infertilities. So these are the ovarian dysfunction. Almost 70 to 80% of women with the PCOS having a oligomenorrhea or amenorrhea. So if we talk about the infertility, 90 to 95% of the women having the infertilities with the anovulation, there is no more ovulation is occurred. So the stopping of the menstrual cycle is occurs. That's why they are considered as an infertile duration of that time, or maybe due to this PCOS or some menopausal age. So if the hyperandrogenism, that's an acne and seborrhea, and the hirsutism doctor, the obesity and hyperinsulinemia. So along with that, the fertility markers, the L with that markers, the insulin marker is also as an increased resistance occurs in around 50 to open marker, in which if they have with the fertility marker, if they have increased insulin levels, so they may help to diagnose the PCOS or other disease condition in which the patient can be treated for the further after the confirmation. So if we talk about the prevalence of PCOS in the different ethnic group, you can see that in different countries, they have a different ethnic groups, and there is steady population has been occurs, and on the basis of prevalence and the criteria and the other finding of different gonadotrophin, eroticism, PCOS, and that the overall conclusion for this prevalence study in the different ethnic groups is the mean premenopausal woman is estimated to be 5 to 10%, and they have a significantly ethnic and racial variation in the clinical presentation of PCOS, the frequency of obesity and insulin resistance. It seems reasonable that the prevalence of the PCO may differ among the distinct population. So these are the outcomes of these prevalence in different ethnic groups, and then the reliability. So if we talk about the diagnosis and the guidelines. So if we talk about the diagnosis and the guidelines, according to the proposed diagnosis criteria for the PCOS is in case of hyperandrogenism, the elevated serum androgen levels, that's in a total testosterone, and the bioavailable testosterone, that's in a free testosterone levels, helps them to diagnose that difference. So these guidelines are from the National Institute of Heart. Rotterdam diagnosis establish 2 out of 3 criteria, and androgen axis and PCOS society diagnosis required hyperandrogenism criteria. So you can see that then hyperandrogenism, the elevated total testosterone and the free testosterone levels, if they have the diagnosis for the PCOS. So if you talk about the oligoanovulation and the polycystic ovulation, these guidelines are maybe some not required, and in some cases it's a positive, and then in some cases gives you positive and may not be a positive in some oligoovulation and ovulation and the polycystic ovary. So these are the diagnostics guidelines for the PCOS. And if we talk about the high DHEA and free testosterone values, you can see here that better metabolic parameters in the woman with the polycystic ovarian syndromes. And then overall conclusion for these two tests correlation with each other is that the DHEA value is if the high and then related to the better metabolic phenotype in the woman with the PCOS, and high level can be used to detect with the woman with the PCO that are high risk of metabolic problems. So this is the conclusion on the basis of these publications and then the author extract. And if we talk about the clinical application of infertility. So according to this Journal of Clinical Endocrinology and the Metabolism, the serum level of aldosterone in IH and PCOS populations are higher than the normal people. So the aldosterone levels of serum levels and their conjugate in normal women as compared to the obese woman and the idiopathic hirsutisms and the polycystic ovarian syndromes cases you can see here. And then they have androstenedione and p value is 0.05 and 0.01, and on the basis of that. So you can see that the androstenedione levels in idiopathic and hirsutism and population is higher than the normal value. So this is also a helping tool for the clinical application of using the androstenedione assay with the other assay in conjunction for the rule out of this PCOS. So it is also suggested that in the hyperandrogenemia may be used misbio if only the testosterone or free androgen index is measured, and the aldosterone should be tested at the same times. So this is the recommendation on the basis of which you can see here the aldosterone levels with the sensitivity and specificity as compared to the free androgen index. That's then a curve of A, and the discrimination of PCO and the control and the control woman. The curve discriminating each of the 3 phenotypes of the PCOS and controls are also shown with the high testosterone level and oligoamenorrhea and the polycystic ovarian morphology. So on the basis of these 3 different diagnoses, these tests are evaluated for with the androstenedione conjunction with that different conditions rule out. So if we talk about the clinical application specificity and infertility about the diagnosis of PCOS, the PCOS about the age factor is 28.60, control value is this, is the plus minus is 1.04 and 1.38, p value is 1. For the BMI based, it's a 27.21 value, and the p value is 0.34, and the menstrual cycle days is 103. On the basis of FSH, LS, HSBG, and testosterone values, the ovary left and right scans are also helpful for the diagnosis of PCOS. So the clinical data from the different parameters, variation in the PCOS, have a combined detection of multiple parameters could improve the accuracy of the PCOS diagnosis. So with the help of these parameters in the PCOS patient, these values are established as compared to the control value and the p values of the different conditions. So if we talk about the clinical utilization of anti-malarial hormone, as we know that it's an effective marker for the granulosa cell tumors of the ovary, and it helps to the diagnosis of children with the gonadal dysgenesis, precocious puberty, cryptorchidisms, and other development disorders. So the diagnosis of persistent Mullerian duct syndrome, PMDS, and the diagnosis of hypogonadism and reflects also the ovarian function is leads towards the ovarian cancers, and the prognosis also this marker can be used at. So if we talk about the test panel total solution for the fertility, the SNIDE has a comprehensive solution for that. Like for the hypogonadisms, we have a menu for the FSH, LH, testosterone, free testosterone, and sex hormone binding globulin. So for the hirsutisms, we have a DHESA, testosterone, free testosterone, androstenedione, and sex hormone binding globulin. For the disease condition of PCO and other infertility, we have a very comprehensive fertility and then this markers for the diagnosis of gonadal panels, which helps to diagnose the infertility and polycystic or ovarian syndromes diagnosis. For the congenital adrenal hyperplasia, we have also a 17-hydroxyprogesterone along with the ACTH and DHESA with the other parameters to diagnose this congenital adrenal hyperplasia. So if we talk about the reagent performance from different as compared to the different with the SNIPE. So if we talk about the SNIPE versus other competitors in the market in sex hormone binding globulins. Okay, pause. Okay. So if we compare the SNIPE versus the other competitors, like Roche, Beckman, Simmons, and Abbott, they also have sex hormone binding globulin assay from their instrument platforms. As of today, we have two generations, the first generation and second generation, and definitely the second generation is improved version of our SHBG, and we have a same technique of sandwich, which while the other, they have also a sandwich principles. With the linearity range, we have a linearity which is much, much better than the Roche, Beckman, and Simmons. As compared, we have very competitive value for the Abbott. And if we talk about the sample value volumes, that's in 100 microliters, sorry, 10 microliters, as compared to the other competitive with the Beckmans and the Abbott's sample volumes. So the sample type, both serum and plasmas are recommended, which is equally good as compared to the other competitors. We have a limit of blank, limit of detection concept in our assays. We have a calibration traceability. That's the second international standard for SHPG, NIBSC code 08266, which is equivalent to the Simmons standardization, while the other Beckman and Abbott, we have no data for that. What they have is standardization against them. So we have a latest calibration traceability. We have a stable calibration frequency of 14 days, and we have an onboard reagent stability of 1 month. So if we talk about the pack size, we have a flexible 50 and 100 pack size. But if those companies who are providing a small reagent test pack size of 50 tests, but the customer need to purchase two kits, so their inventory contains 100 tests, and the onboard capacity pack size is a 50 test, while the reagent pack size is 100 tests. Any question? Okay. So if we compare this commercially available sex hormone binding globulin, our first generation, we have a regression value of 0.98 on the basis of 122 samples. We have excellent correlation with the commercial available sex hormone binding globulin. If we talk about the meglumi androstenedione, we have a competition with the Siemens and the DRG, and they have a correlation with the first generation and second generation. We have a chemoluminescence immunoassay technique, while the DRG is a manual ELISA based technique, but they have an androstenedione on their portfolios of their menu. We have a just 10 microliter sample aspiration as compared to the automatic androstenedione available on the automation. We have a test duration is 19 to 23 minutes as compared to the DRG, and the Siemens maybe have different times, but they are, I'm sure they are higher than the SNIPE assay time. So we have a limit of blank, limit of detection, and our linearity range is between 0.08 to 10 nanogram per ml. The calibration frequency, our assay is a 1 week, and the pack size is 50 to 100 tests. But the challenge with the other automatic system is that 200 test pack size is there. We provide QC and calibrator along with the androstenedione reagent free of cost, but they need to purchase QC because they are only providing a calibrator along with the androstenedione. So the automation that we have a fully automation, Siemens have also a fully automation, while the DRG is a manual procedures. So if we move more about the other assays, like method comparison of our androstenedione first generation, we have a regression value of 0.98. And then there we have available with the commercially available androstenedione. So if we talk about the free testosterone, so the test kit size, we have a 50 test and 100 test, and this analysis is the quantitative and the based on the competitive principles. In the second generation, we have an edge of serum and plasma both recommendation, and the traceability USB reference standard, and the calibration interval is 28 days. The sample volume is 40 microliters, LOD, and the linearity is 0.25 to 150 picogram. The onboard stability is 1 month, and along with the reagent pack, we are providing free of cost 2 level of quality controls that help the customer to check the performance of the assay from the lower end to the higher end as well. So if we compare our testosterone first generation with the commercially available other free testosterone, that the regression value is 0.98, which shows excellent correlation with the other commercially available testosterone. So if we talk about the AMH, anti-Malarian hormone, we have a 2 generation. We have a competition with the Roche and the Beckman. They both have a sandwich principles, and the sample volume is just a 40 microliter, which is equally good as compared to the Roche and Beckman. The sample type, both plasma and serums are recommended, and the LOB, LOD, and LOQ concepts is more better, and then the reliability of in terms of linearity is better than as compared to the other competitors. If we talk about the calibration frequency, after the 1 month calibration frequency is recommended, we are providing free of cost calibrators and controls with the reagent, while as compared to the other Roche and Beckman, they need to purchase separately. If we talk about the reagent onboard stability, we have a 4 week stability, and the Roche has a 16 week stability, and the Beckman is not available at the moment. The pack size, we have a 50 test and 100 test, but they have a no flexibility of the lower pack side except the Beckman. But the original, the kit pack size purchasing is 100 test. So after the 100 test, they have a 2 cartridges. Each cartridge contain a 50 test. So they can load on an instrument the 50 test, but their purchasing price is 100 test. Okay. So if we compare the anti-malarial hormone first generation with the commercially available AMH, the regression value is 0.99, which shows an excellent correlation between the SNIB AMH assay versus the commercially available anti-malarial hormone assays. So, if we talk about the marketing potential, as you know that the global infertility primary prevalence among the women who seeks a child is in 2010. According to that, the prevalence indices is age among the age standards and between 20 to 44 years. You can see that the fertility potential markets in the Asian countries, in the Middle East countries, and in the European countries are more as compared to the 3% more potential in these countries. Like the other countries have a potential of the countries like the European countries, the Russian areas, and then the countries which are in the North America and South America, Mexico, Brazil. These countries have a more percentage of the primary infertility between 2 to 3%. And then those countries who have also a very less than 1% of prevalence of the primary infertilities also exist. So on the basis of that, this is the market potential, and on the basis of these market potential, we have a very comprehensive menu within the chemiluminescence immunoassay technique. If we compare the SNIDE menu, we are on the top line because we have few analytes which are not available with any other chemiluminescence immunoassay manufacturer side. Like so, we are number one in infertility markers because especially the 17 hydroxyprogesterone and free testosterone. These are the niche parameters which are not available with any other IVD market automation providing companies. Only the Endostrine Dione is also available with very few companies, while the rest of the companies have a deficiency of having these analytes. So we have a very broad menu, and we have a one window solution for the infertility panels, and we have across the board the same reagent pack. If the customers want to switch from the Meglumi X3 to Meglumi X800, the same reagent pack can be used for both the analyzers, and then can be used for the patient testing reporting. So this is about the comprehensive menu of SNIDE. And if you have any question, you can ask about that. So let me give you a little bit more information. Oh, sorry. I have to share the screen. So if we go for previous slide about so just give me a 1 minute. Okay, sorry. So that's my key message for that marker is that if the hospital or a clinic which has some gynae patient or they have some IVF centers, these assays are clinically more important like FSH, LH, estradiol, progesterone, and prolactin. All these assays, okay, so the all these assays are very much clinical significant, especially when they have induced a pregnancy or they are providing a hormonal therapy to the expected pregnant women. Their E2 and progesterone levels, along with the prolactin levels, periodic monitoring helps them to compare with the ultrasound and contains the about matching with the follicles. So it has been practically observed with the Roche assays of estradiol and the progesterone, they are not clinically correlating with that induced maintenance of the estradiol and progesterone, and on the basis of which the number of follicles are not correlated with them. So usually they need a second opinion, so they send that assays like estradiol and progesterone for the further verification on another analyzers. So these are the key assays which help in this artificial induction of these hormones in IVF patient, and the true picture is not observed with these competitors. So they can use our estradiol, progesterone, FSH, and LH to diagnose with the patient. So this is the most important thing that I would like to share with you. How many exactly are estradiol kits for evaluating children's indicators? Okay. So honestly, I have no idea about that because if you are talking about uh, if you are talking about the estradiol evaluation of the children indicators, it means you want to establish the reference range for children anomalies or the reference range of estradiol for the children's. So you need to based on the CLSI guidelines. So if you give me 1 minute, I can share with you for the reference range evaluation for the pediatric according to the CLSI guideline. Just give me a 1 minute. I have to search in my folders, and I will give you the right answer. So let me check. Um, about the Indus Hospital's validation protocol. Excuse me, Indus Hospital validation. Linearity and then reference ranges. Comparison. quantitative method comparison, CNSI, yellow Q, reference ranges evaluation. So I would like to share with you my screen. So please tell me that can you see my screen? Excuse me. So you can see my screen? Okay. Atoms. So the urine. So urine, this is the CLSI guidelines according to the C22, C28. The interpretive information for the laboratory test that is frequently provided as the central 95% of interval for the group of well-defined reference interval. So if you want to evaluate the reference ranges, the reference ranges for estradiol for the children's. So you can go for that, and you can have to verify the normal range of the population. Your question was that. I hope I understand the right thing. So you were talking about the reference range or the normal range of the population, because as of today, the estradiol values in the pediatrics range, and that's different. So you have to obtain a 20 normal samples, donor specimen. You have to run these 20 specimen and check the outliner outside the normal. Is the acceptance criteria is this? If it's failed, then you have to need to establish the normal range. So how you establish the normal range? This is then in criteria. Like if you go to the little bit down, you can see that to establish a normal range, you need to have 120 normal samples for each sex and age. If you are evaluating the pediatric range or a neonatal range, you have to go to a 120 normal sample for male and 120 normal sample for the female, and run in EP evaluator to establish the normal range, or any outlier should be removed from the experiment if this exists. So the minimum 120 samples are recommended. So the verification of the reference interval is there. So you can see there's a reference interval, there is a statistic analysis, and on the basis of this reference internal histogram and the result distribution on the difference interval, this is was the experiment has been done, and then they have established that reference interval. Okay. There are two processes. Either you have to reference interval verification. The verification can be done by the just the 20 samples. But if you want to do a reference interval establish, you need 120 samples for different age and the different sex as well. So I have one more document. Let me share with you. Just give me one more second. I will share with you. This is